introduce our first speaker, Dr. Eli Muchtar from Mayo Clinic, a fantastic colleague and a true expert who's doing great work in the field of amyloidosis. As you'll hear, some of that work is related to making the diagnosis, but particularly focused on prognostic factors and assessing response. And I can't think of a better person to be talking about this than Dr. Muchtar. So, thank you.
Thank you, Dr. Zonder, for this kind introduction, and I'm very happy to be here. And thank you also for the generous invitation for this symposium. So my name is Eli Muchtar. I'm from the Division of Hematology at Mayo Clinic, and I will be discussing making the diagnosis of amyloidosis and assess the prognosis. These are my disclosures. And for the specific objectives of this talk is to educate about the importance of making a timely diagnosis in this disease. We'll learn about the diagnostic techniques to secure the diagnosis and also discuss the prognostic factors in this disease. As far as the journey to diagnosis, this is different between patients. But generally speaking, the journey is not a straightforward one for many of those patients. You can look at this data from this online survey. Most of the patients need to endure more than 6 months until the diagnosis has been made since their initiation of their symptoms. And for a large portion of patients actually count in years. And during this time, they are seeing multiple physicians, sometimes from different disciplines, undergoing diagnostic testing. Some of them are very comprehensive, and then being told that everything is okay, they haven't found anything, while their symptoms are actually getting worse. Or they are being given diagnoses such as renal failure or congestive heart failure, which are not very specific and not very helpful in promoting the treatment of those patients. Or they're getting a misdiagnosis. So I've seen several patients being diagnosed with asthma when they have shortness of breath on exertion, or very commonly CIDP for their peripheral neuropathy. So they are being given a false hope, and in addition, that further delays their diagnosis. It is important to understand what are the barriers for making a timely diagnosis in this disease. And the first barrier is the patient perception of their symptoms. Many patients, especially at the beginning, because symptoms are usually gradually increasing, they think that their symptoms might be related for process of aging. I'm just getting old. Or they think that those symptoms may go away. It's like a temporary, it's like a flu. Or it might be a side effects of their medication. So this is the first barrier. But once they cross this barrier and they come to seek medical attention, then the major barriers are within the medical system. The symptoms of amyloidosis, and unfortunately I cannot describe it too much in this discussion, are not very specific. And given the fact that the diagnosis is not very common, that pushes down amyloidosis in the differential diagnosis list quite down the list. So it's really not coming up as one of the first things that physicians think about. Now, the presentation of amyloidosis is quite diverse. There are multiple presentations, and because of that, there are multiple entry doors for those patients. They can go through the cardiologist door or pulmonologist or the primary care or hematologist. And it's important who sits behind that door. Is he or she are aware of amyloidosis? Have they seen patients with amyloidosis? Have been know how to work patients with amyloidosis? Those are things that determine the course of those patients. And last and not least is the requirement for tissue diagnosis. There is no such thing as clinical diagnosis of AL. You need to confirm the diagnosis on a tissue biopsy that need to be obtained. This is not kind of a tumor or a lesion. This is kind of a random biopsy from the tissue. And until this tissue diagnosis has been made, you can't really say that the patient has amyloidosis. So this is another factor that delays diagnosis in this disease. Now, we say that AL amyloidosis, and specifically AL amyloidosis, but other forms of amyloidosis as well, is a race against time, and we need to shorten the time to diagnosis. And I want to explain why. It's really important to understand why early recognition is so important in this disease. As I was alluding to, amyloidosis is a progressive disease. So early diagnosis will mean that the patient will be diagnosed at this stage when there are few symptoms and only mild organ damage occurring at that time. We can offer more treatment options for those patients, and also importantly, we can reverse the organ damage. But if diagnosis is not made at this golden hour, symptoms will progress, and some patients will progress quite rapidly. Patients become quite symptomatic. Basically, their end-stage organ damage can be multiple organs, and this is a point of no return. Whatever treatment that you will give to those patients, you cannot alter their natural course of their disease, and most people will be dead just because we haven't diagnosed them early enough. Now, we always try to educate and promote early diagnosis, but we need to think about maybe other ways that will allow us this early detection. And this is kind of 2 slides about artificial intelligence and how it can maybe help in making this early detection. So this is an AI ECG. This is an algorithm that was developed at Mayo Clinic. It wasn't developed specifically for amyloidosis, but it was included cardiac amyloidosis as well. So this algorithm was trained on hundreds of thousands of ECGs. Some of the ECGs from patients with no cardiac diagnosis, and some patients were with certain cardiac diagnoses, including cardiac amyloidosis. And the algorithm was able to detect changes in the ECG. Most of them, by the way, are not visible to the human eye, that will distinguish cardiac amyloidosis from other cardiac diagnoses and normal ECGs. And it provides a score from 0 to 1. So 0 is the lowest probability of cardiac amyloidosis, and 1 is the highest probability. And each dot represents a different ECG, and this is the timeline. So this is a patient of mine diagnosed in 2020 with cardiac amyloidosis. This was AL type. But she presented a year earlier to her primary physician saying, I have pain in my arms when I have a long walk. And that primary physician ordered an ECG, and the ECG was read as normal sinus rhythm, so no further cardiac workup was done at that time, and eventually she added the cardiac workup a year later. Now, at that particular time, this AECG was not available. This is a retrospective look at the ECGs from that time, but imagine that this AI ECG was available for that physician. He could have looked at that and maybe ordered a test and make the diagnosis 1 year earlier. Now, if we want to look at it in a broader sense, not only on the ECG, because this is more specific for cardiac amyloidosis, maybe we can harness all the information stored in the electronic health records to create, through a process of machine learning, understanding the phenotypes that can be taken out from the electronic health records, and create a screening model that will help to understand that a patient that you just saw may have amyloidosis. Now, an important step in this process is identifying the signs and symptoms of AL amyloidosis from the electronic health records. So we have signs and symptoms; those are important. We have imaging, we have testing. Now, this is a crucial part because we need to train the computer to understand human language. And so in this study, there was it's called natural language processing, or NLP, for those who are interested. So an NLP algorithm that is specific for amyloidosis was created. These are 15 signs and symptoms of amyloidosis, including dyspnea and edema and neuropathy. And the investigators looked at the ability to abstract the data from the EHR using this NLP algorithm versus a person manually abstracting the data. And this is the performance for one of those signs and symptoms. This is specifically for proteinuria. And you can see that the AI-based approach and the registry, which is the manual abstraction, had pretty much equal quality of abstraction of the data. But obviously, using an AI-based approach is much more time efficient, and cost-effective. So once we cross this barrier, we have an LLP algorithm, we can now incorporate it into a model that will screen with other things stored in the electronic health records to create a model that will alert the physician about the possibility that the patient may have amyloidosis. Now in the second part, we'll discuss about the making of the diagnosis. So when should we suspect the diagnosis? Now it's hard to put in one slide the multiple presentations of amyloidosis because there are truly many. But we should focus on the things that are usually commonly seen in this disease. This is kind of the first start. And these are, I put in those here, and you can see them, patients with persistent proteinuria that has no other alternative explanation, patients with heart failure with preserved ejection fraction, patients with neuropathy, patients with hepatomegaly, and also patients with monoclonal gammopathies, MGUS, motoring, myeloma, Waldenström macroglobulinemia, that have a typical presentation. Now, it's hard to say what is exactly atypical, but for example, if a patient with Waldenström presents to your office and has a profound edema, then maybe you should check 24-hour urine, or maybe you should do an echocardiogram, maybe searching for the nephrotic syndrome or his heart failure. Now, as far as workup, it really depends on where the patient starts and what are the symptoms of those patients. And we won't discuss it because it's really might be a long discussion. However, there is a common pathway for screening patients with AL amyloidosis, and this through the use of the monoclonal protein studies. We have 3, and those are listed here. And we know that all patients with AL amyloidosis will have at least one abnormal study. So if all testing are being ordered and are negative, we pretty much can rule out the diagnosis of AL amyloidosis. There might be some other forms, but AL amyloidosis, it's very, very unlikely to happen. If it's positive and you are suspecting amyloidosis, you cannot make the diagnosis. You need to confirm the diagnosis. And this is using a tissue biopsy, which shows the congregate positive deposits, the amyloid deposits. Now, we can go into the organ that is affected and get the biopsy from that, but we prefer less invasive biopsies. Obviously, it's less risky to the patient. It is less costly. And in AL, this is specifically true because we can find the amyloid in more accessible tissues, and this is the bone marrow and the fat aspiration. If you look at this pie chart, 90% of patients with AL amyloidosis will have amyloid deposits either in the bone marrow or in the fat. So it's only really 10% of patients, if you order the bone and the fat, and there will be negative in those 2 tissues, then you need to go into the organ and get the biopsy from it. We know that men and patients with limited organ disease are more likely to require organ biopsy, but also look, lack of fat aspiration. So close to 20% of patients are marrow negative, fat positive. So if you don't do the fat, then you need to go into the organ and get the tissue from that. So we definitely can spare for most of the patients the need for an organ biopsy. Now, once we have demonstrated the amyloid deposits, we haven't finished our diagnostic process, and the crucial next part is the typing. And I say it's crucial because therapy is guided by the type that we determine. We don't have a pan-amyloid therapy, at least not today, maybe in the future. So we need to know the type because we need to guide the therapy based upon it. And typing must be done on the tissue. We cannot assume that if a patient has amyloid and has a monoclonal protein in addition, that this equals AL type, because you will be wrong in some of those assumptions. So again, typing must be done on the tissue. The gold standard is using mass spectrometry. And we say it's a gold standard because the quality of the data that we're getting from this typing. So what happens is that the amyloid deposit is actually microdissected from the tissue, and then it's goes through some chemical degradation using trypsin, and then there is a sequencing of the peptides that are received from that amyloid deposits. And using a library and a software, the laboratory can determine the protein composition of the amyloid deposit and what is the leading protein which causes this amyloid deposit. So it really is a very accurate method of typing. Now, it's not available in most centers, although many do send it. So if you have ability to send it, that probably will be the best way to do typing in amyloidosis. The other options that we have are the antibody antigen typing methods. This is, for example, immunofluorescence, immunohistochemistry. They have higher false positive and false negative results. So if you're using that, it's better that it will be used in a laboratory that is skilled to minimize those false results. Now, once we secure the diagnosis of amyloidosis, we need to do workup that goes into two directions. We need to assess the what is the organ that are involved in that patient, and we need to assess the clonal disease. As far as the organ assessment, what I put in the upper box is things that are routinely done because either because those organs are quite prevalent in this disease. Heart and kidneys are seen in 16 to 80% of patients, so it very makes sense to screen those two organs. So for the heart, we're doing ECG, echocardiogram with strain, cardiac biomarkers, NT-proBNP or BNP, and troponins. Those are important because we can determine the stage, and we'll discuss it in a minute, but also we can assess using those parameters the response to therapy. So those are really important to obtain at baseline. Some patients, it's hard to determine if they have cardiac involvement, and this is where cardiac MRI may be helping you. For the kidneys, we're doing creatinine, albumin, and 24 urine protein. Again, this is important first to determine if the organ is involved, but second, to assess the response if the organ is indeed involved. We do screening for liver and coagulation profile because those are blood-based testing, those are prevalent, and it doesn't cost a lot to make those. So alkaline phosphatase, bilirubin, coagulation profile, known as factor 10, but there is actually more than just that. We'll hear from Dr. Abnur about that. So once we finish this, and there are other tests that might be done based on the clinical presentation of the patients. If you suspect autonomic involvement or if you suspect GI involvement, you can do some more testing to verify. We also want to understand the clonal disease, the underlying clonal disease. So this is using the monoclonal protein studies that may have already been done because you've been suspecting the diagnosis. And those are important because, again, they will be used for assessment of response, so we need to get that baseline close to the diagnosis. And also a bone marrow biopsy because we need first to understand what is the underlying clonal disease. That's typically a plasma cell clone, but it can be a B cell clone. And we want to order a FISH because that may help us in decision-making down the road for those patients. And the last part that I will discuss is on prognosis in this disease. This is a slide I like to show because it well demonstrates the significance of cardiac involvement in this disease. So as I said, kidneys and the heart are the two major organs in this disease. Now let's look about the survival of patients that have those organs as a sole organ involved versus a multi-organ. Let's still start with the kidneys. So you see in the red curve what happens to the survival over time when the kidneys are the only one to be affected, and what happens to the survival, how greatly it drops the survival once there is more than just the kidneys. But for the heart, it really doesn't matter. Whether you have a single heart involvement or part of a multi-organ involvement, the survival is quite dismal, regardless of how many organs are being involved. This is how crucial the heart involvement, and unfortunately, it's quite prevalent in this disease, for survival. This is why we have the cardiac staging. This is a staging that is based on the cardiac biomarkers, the troponins and the natriuretic peptides, to assign risk group and understand what the survival of those patients may look like moving forward. The first staging system was the 2004 Mayo staging system that was modified later on. This is solely based on cardiac biomarkers, the troponin T and NT-proBNP, and this is the cutoffs. And the modification is when they took stage 3, which has the two biomarkers above the threshold, and separate that in 3A and 3B using a higher threshold of NT-proBNP. The advantage of this cardiac staging system is that it singles out the patients with a worse prognosis, people that have really poor outcome, and most of them die within 6 months of their diagnosis. The other staging system is the Mayo 2012. This based again on troponin and NT-proBNP as the first system. This is a little bit different cutoffs, but also add to it the DFLC, which is the measurement of the involved light chain minus the uninvolved in the blood. And again, you get a 4 nicely separated out survival curves for those patients. So this is the cardiac staging. Now, those cardiac staging were developed using the troponin T and the NT-proBNP, but other centers use other cardiac biomarkers, and we have, for example, the high sensitivity troponin T that was introduced some 5 years ago. So we have this conversion tool with work from several centers that you can actually assign the cardiac stage almost with all the cardiac biomarkers available. So you can use that in order to assign the cardiac stage of the patient. The renal staging, it's a different staging system. It's based on the measurement of the organ, the severity of the organ damage. But as I've shown, renal involvement is less effective for survival. But we know that patients with renal involvement are more likely to go into dialysis. This is a very poor outcome for those patients, and this is the purpose of this renal staging, to estimate what is the risk of those patients going into dialysis moving forward. So for example, this is a 3-stage system. The stage 3 is when the proteinuria is more than 5 grams and the eGFR is less than 50, and you can see both in the testing and the validation cohort, a good separation of the curves of the risk going into dialysis between those 3 stages. Now, we have other prognostic markers in AL amyloidosis. There are factors related to the organ involvement. We know patients with autonomic and liver involvement usually have a poorer survival. We know that there are factors related to the underlying plasma cell clone. The percentage of the bone marrow plasma cells can have an effect on survival. We know that the fish genetics either have an impact on survival or on the response to therapy. So these are very important to obtain at baseline. And we also know that the response to therapy is quite crucial for survival, both the hematological and the organ response, and hopefully we can discuss it in the Q&A session. And now I have the question, right? So are you presenting it from this slide? Okay, so this is a question about diagnosing of AL amyloidosis, and I want you to please choose what do you think is true, what is the true statement here? A negative congruent staining on a bone marrow specimen rules out all types of amyloidosis. B, positive congruent staining on a bone marrow specimen confirms the diagnosis of AL amyloidosis. C, which I'm sorry that I haven't touched, a positive PYP scan confirms the diagnosis of cardiac AL amyloidosis without the need for a future test. D, tandem mass spectrometry and a tissue biopsy is the best way to confirm diagnosis of amyloidosis light chain type. And E, in most cases, AL amyloidosis can only be diagnosed after biopsy of an organ suspected to be affected. Please vote. Wow, 88%. You're the right answer. Okay, that's good. Please take it into your clinic. My last slide will be, summary. So we discussed the importance of making an early diagnosis. What are the challenges that we are facing in reaching this early diagnosis? We discussed about new ways, hopefully will come in the next years, the AI-based approaches to make an early diagnosis. And by the way, this cardiac algorithm that I showed you, the AI, the ECG, it's available for clinical use at Mayo Clinic. There are no alerts, but clinicians can look and maybe get information from that and maybe move forward with early diagnosis using that tool. We discuss about securing the diagnosis with a tissue. You cannot make a clinical diagnosis of AL amyloidosis, and that there is really no need for organ biopsy for most patients, not all patients, but most patients. We discuss how crucial it is to make accurate typing in order to deliver a proper therapy, and we discuss both the cardiac and the renal staging, which measure the severity of the organ damage, but also being used as an outcome surrogates in this disease, and those are important staging systems for communication, understanding what the patient is like moving forward. Thank you very much for your attention.
Bring up the next slide because it's hard to speak and introduce.